All right. Okay, so we're starting a new chapter this week, and just like last week, we'll spend the whole week talking about this particular. Um, looks like someone joined. One sec. Uh, okay. Sorry, so I'm trying to let someone in. So we're starting a new chapter. We're done with the anxiety and obsessive compulsive disorder section. So we're moving on now to emerging personality disorders, which is actually not in your textbook at all, and it's often not covered in abnormal child psych classes, but it's something that I think is really important to be thinking about. And there's a lot of research, which we'll talk about in a little bit, about emerging personality disorders. So, talking about personality disorders as they onset in adolescence. So, we'll talk about some of the controversies and why, in general, clinicians or people who are not researchers, or even some areas of research that are just not familiar with personality disorder, um, seldom talk about this kind of stuff, but it is important to be thinking about. So, I've added this. Um, Hopefully, you'll learn a few things. So as far as what we're doing this week, we're here today, Monday, because there's no textbook reading, because it's not covered in the text, I've assigned these two papers. So there's the Sharp and Fonagy article. So it's a journal article that I pretty sure I gave you access to, so you don't have to like go through the UH library or anything like that. So I pulled it out and it's on Canvas. And then the other thing is the Steiner and Allen. I believe it's also a journal article, or it might be a chapter. I can't remember. That one I think is a little bit lengthier. So just make sure you get a chance to take a look at that, just because there's no textbook supplementing this. This is where you're getting all information is from me and the readings. So Monday, today, we're going to try to get through as much as we can. We have guest speakers on Wednesday, and so we're not going to if we don't finish the lecture, really on Friday is your time to independently review, because we have a flipped classroom, which just means, again, we're not meeting, use the time to independently read the readings and look through the lecture slides. So hopefully we get through a lot today. Anything we don't cover today, do on your own on Friday. Come to class Wednesday, because we have two guest speakers, which we have not done before. We usually have only one. So it's going to be packed with two people. And then just a reminder, I sent out a notice on Canvas, I think like last week or maybe the week before, just letting you know that I had made some syllabus changes. So we have we have a flipped classroom this Friday, so in 4 days, but I also got pulled into a meeting that I cannot get out of during next Friday's class time. So we have this week and next week a flipped classroom on Friday. And I think that's it for now. Yeah, assignment 4 will be due next Sunday, not this Sunday. Okay, so selfishly, because we're talking about personality disorders, I think this is just a good segue to talk about why we're talking about it. What do I know about it? What do our guest lecturers know about it? So I've mentioned this before in week 1, and I think it's on Canvas about the little about me slide. So this is my lab. This is the developmental psychopathology lab here in the psychology department. And in the middle is our advisor. She's my mentor, Dr. Carla Sharp, and she has been very influential in the personality disorder field, especially when it comes to research on adolescent personality disorder. So prior to really a lot of her work, which is very seminal, really wasn't that much out there. And so I feel very lucky that a lot of the things I'm talking about are things that I've learned from her and from her work and in our work in the lab. So that's kind of where my credibility comes from, is spending 4 years here, doing a lot of reading, doing a lot of research, as well as our guest speakers. So obviously you can see me in the picture. I'm in the only brunette really in the lab, but our guest speakers are Tess and Kennedy, who are third year PhD students in the same lab. So because we're in the same lab, what that means is we do similar research. And so I invited them to come talk. I believe Tess will talk a little bit more about some of the clinical side because of our clinically with personality disorder. I think I've also asked her to maybe talk about some of her parenting work. So I'm a big parenting attachment person, especially in the context of personality disorder. So is Tess. And then Kennedy, we all have to do clinical work, but Kennedy's interest really is in research. And so she'll talk like a little bit about where research is heading in this area. So those are who our speakers are on Wednesday. Make sure you come. As usual, it's not recorded, and there's going to be questions on the exam. Okay, so just starting off with not necessarily personality disorder, but what is personality? And remember, this is dictated by the research. This is how we think about it in the field. It's going to be different, perhaps, than from what you hear colloquially when we say so-and-so's personality when we talk about things casually. So in general, personality is a relatively stable pattern of thoughts, feelings, and behaviors. A personality trait is an aspect of personality that is also stable across time and across situations. So while our mood can go up and down, it can fluctuate, personality itself stays relatively stable across the lifespan. So I just had an extra thought that I completely lost. Oh, okay. I just remembered it. So something I don't have here is that we're born with temperament, right? Or temperamental traits. That's why, again, when we do the developmental psychopathology model, and I ask, what are some of these early predisposing factors? What are some of the genetic, early individual level contextual risk factors? Things like temperament are going to come into play. So difficult temperament, easy temperament, slow to warm up temperament, aspects of behavioral inhibition. We talked about that stuff last week. So temperament is kind of like what you're born with, what we're coming into the world. Personality kind of lies on top of that. And so they're very closely related. And so temperament research is going to talk about personality research, and those two things are going to like kind of be used interchangeably. But for now, think about personality as stable. The traits that we have are relatively stable, and that's different from mood, which is more fluctuating across time. So personality traits, like we said, is an aspect of personality and also generally remains pretty stable. There's been a lot of research about how we derived the agreed upon traits. So most research supports a 5-factor model, which is the Big Five, or the OCEAN acronym, which you might have heard of before. And so these are dimensions of certain personality traits that theoretically most people lie somewhere along this continuum. So low to high, again, dimensional, low to high levels of a particular trait. So the O in OCEAN stands for openness to experience, C is conscientiousness, E is extroversion, A agreeableness, N neuroticism. So we lie somewhere along each of those traits. And we're not talking about psychopathology yet. This is just where everyone lies. So this is normative personality that we're talking about. Something that I just plugged in here that I didn't teach about last semester, but has been coming up more and more is how do things like Enneagrams play a role? So like, what about your Enneagram type? So it's just something that's like commonly used in like pop psychology. As far as research goes and as far as the personality field, as well as the personality disorder field, it's not supported by research. So all of these like 9 types, it's like fun to talk about. I know where I lie. In my lab, we make fun of this and we say like, oh, we've all taken the Enneagram type test. So it's for us, it's for fun. But as far as being a validated measure of personality traits, the way this Big 5-factor model is, it's not supported by research. It's just something that is fun to do. And I think if people are interested and believe in that, I think there's clinical use of it. But as far as has it been validated as an actual personality measure, it has not. So there's not a huge and not a real evidence base. So just thought this is interesting. During 2020, there's one systematic review at the time that was looking at, are there indicators of validity within the Enneagram? And really there wasn't much. So that's just a segue, or sorry, an interesting thing that I wanted to mention. So personality, we think of the 5 traits, we think they're stable, and everyone's going to lie on the continuum. Where we start to think about personality disorder is when things start to go awry, and some of those traits may play a role. So the DSM defines personality disorders as an enduring pattern of inner experience and behavior that deviates markedly from the norms and expectations of the individual's culture. It's pervasive and inflexible, has onset in adolescence or early adulthood, stable over time, and leads to distress or impairment. So again, that's mapping onto our definition of personality, what it is. And this is where it becomes maladaptive or pathological to the extent of having a disorder. Something to note just with the DSM changes, and this is going to become important later, is that pre-DSM-5, so remember DSM-5 came out in 2013. Before that, we used DSM-4. And they had an access system, and that was used to, there was like access 1, 2, 3, and access 1 consisted of all mental disorders and substance use disorders, and access 2 was generally referred to as like the more challenging disorders or harder to treat disorders, and personality disorders and intellectual disabilities were placed into that axis. And so in like already you can see that it has been considered hard to treat, a lot of stigma about personality disorder, and especially just even in where it lie at the time in the DSM separates it from other disorders. So more on that later. So by DSM-5, 2013, we got rid of the access system. Again, it still had the different 10 different personality disorders, which we're going to cover. So that's the categorical system. But something that's interesting is by the time DSM-5 got published, we did away with the access system. We kept our 10 disorders, but in section 3, and I'm going to explain what that means. At the very, very back of the DSM, there's a section called Section 3, and it's meant for emerging conceptualizations, what new research is finding, relevant things like clinical formulations that you might need. Those are like some of the emerging things out there, but perhaps haven't been adopted yet into Section 2, which is what houses all the disorders. And so for the first time, the alternative model for personality disorders emerged in Section 3. So now we have this new conceptualization, this new model that's in writing proposed in the DSM. It didn't replace Section 2, but it's now finally in there. So my advisor and a lot of the research in the last, I don't know, 20 years has really, really pushed for this alternative model. It's a dimensional model. And we talked about this a while ago when we talked about like HiTOP, RDoC. That's really where the field is moving. But as far as DSM, the clinical gap, there's always a research to clinical gap. And so that's why it's not officially in Section 2 of the DSM, it's listed in Section 3. And so by the next iteration of the DSM, DSM-6, we're hoping, and there likely will be some more movement as far as how will the new DSM, how will the new personality disorder model be integrated into the primary DSM. So we'll talk about that, I think, like halfway into the class, like what is the alternative model? This is what I was referring to, so like the sections. So section 2 is the big section. So I put screenshots before in previous lectures where I say like, here are all the disorders under the anxiety section. Here are all the ones under neurodevelopmental. So that's like in the primary section that people flip to. That's DSM section 2. Section 3 is the emerging models that we'll talk about later. So for our purposes right now, we're going to focus on the diagnoses that are actually in section 2. This is what we see discussed the most. This is what clinicians are most familiar with. So this is where we'll talk about the 10 personality disorders. So it gives you a overview of what personality disorder is in general. So common to all, whether or not you give a specific disorder. It says that, again, it's an enduring pattern of inexperience and behavior, deviates from the norm, and there needs to be issues in 2 or more of the domains of either cognition, affectivity, interpersonal functioning, or impulse control. I'm going to skip this because we already read the definition. What's really important is that you know, as far as the categories, what the different disorders are. So there are 3 different clusters, cluster A, B, and C. And within each cluster, there are specific diagnoses that fall within that general theme of the cluster. So in cluster A, we think of this generally as like the odd eccentric cluster. And so within this, we have paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. So paranoid personality disorder, and remember, this is a diagnosis, it's pathological. It's not the same as like I'm sometimes paranoid. This is a pervasive pattern across time. It's impairing, it onsets in adolescence, all the things we just talked about. So, but one of the hallmarks of paranoid disorder, personality disorder is distrusting and suspicious interpretation of the motives of others. So very, very suspicious, becomes very harmful or impairing in their life. Schizoid and schizotypal, I think people get confused. Schizoid is this like detachment, like social detachment, and you see a lot of restricted emotion. Schizotypal is, it looks kind of similar, but it's more about social discomfort, and you see more of the oddities or the eccentricities in thinking. So this schizotypal can sometimes mirror schizophrenia a little bit. When people come into treatment, they say like this teen has had, or this person has had like really bizarre thoughts, but it doesn't feel like schizophrenia. I'm not noticing it's schizophrenia. It doesn't feel like any of the other psychotic disorders or any of the schizophrenia form disorders. I'm not sure what this is. It might be schizotypal if it falls within the PD, realm. Cluster B is thought of as the dramatic and erratic cluster, and I don't really like that like theme that it has going, but basically this is where it houses antisocial, borderline, histrionic, and narcissistic personality disorder. So this is having to, you see more of the ups and downs with this one, if you feel more of the interpersonal disturbance with this one. So antisocial is disregard for and violation of the rights of others. This one, we hear a lot of conversation about conduct disorder, perhaps being related. Borderline is generally an unstable relationships, poor self-image, affective lability, and then impulsivity. Histrionic is excessive emotionality and attention seeking, and then narcissistic is grandiosity, need for and admiration, and at times a lack of empathy. Cluster C is our last cluster, and that's the like anxious, fearful cluster. There's avoidant, which is kind of marked by anxiety, which then leads to this feeling of inadequacy, hypersensitivity to others, and negative evaluation. Dependent, which is a submissive behavior, needs to be taken care of. And then obsessive compulsive, which is preoccupation with orderliness, perfection, and control. It is not the same as OCD. This is a personality disorder, whereas in OCD, we view those obsessions as like true obsessions and compulsions. So I say all of this because this is the 10. This is what most people talk about when they're talking about personality disorders as a whole. When it comes to personality in adolescence, most research has focused on borderline, so BPD. Um, and I think something that's important to note here, and it even is in the DSM where it says symptoms onset in adolescence. A lot of people, and we'll talk about it the next bullet point, a lot of people are concerned with giving a BPD or any PD diagnosis, and in part because they think that it doesn't happen in adolescence, it must happen later on. And what we know from research, decades and decades of research, is that symptoms usually do become apparent in adolescence and they don't just crop up all of a sudden. It's kind of like when people say, like, oh, when you turn 18, you're an adult. Yes, legally, but like nothing really changed. Like, there are things that you were doing as a 17-year-old that kind of carry forward into your adult years. So, same thing with PD, they don't just crop up all of a sudden because you became an adult. A lot of these symptoms onset in adolescence. However, it's often not assessed or even, so it's definitely not diagnosed very often and certainly not assessed as much because clinicians are usually really, really uncomfortable with diagnosing PD in young people. Some of those caveats or some of the hesitations they have are for the things that I've outlined here. So sometimes people say, oh, like PD is not even allowed to be diagnosed until you're 18. As we saw on the earlier slides, that's not true. You can diagnose it. So that's this arbitrary rule that people have come up with. That's a myth. You can diagnose personality disorder below 18. Now we're not using it like liberally, right? We want to make sure that it's actually a personality disorder. But again, there's no like rule saying you can't do it below 18. Of course, a lot of concerns about stigma. So, oh my gosh, if I say this person has personality disorder, if I say they have BPD, I've heard this literally, it's a death sentence. It's like their life is screwed. Like, why would I do that to them? So that statement, while it's well-intentioned, trying to help a person from facing stigma, that statement by the clinician reinforces stigma. It's something to be scared of. I don't want to put you in that position. So there's definitely concerns about stigma. Um, Also just not a lot of knowledge about how borderline features is different from more normative trajectories of adolescence. So people say, same thing with this next one, believe that because identity is still forming, a personality disorder PD diagnosis is not warranted. This is where the developmental psychopathology and more of an abnormal child psych understanding really helps. And I wouldn't say that most master level clinicians probably have that model in their head, because it's most often used in research and clinical science. But if we keep our developmental psychopathology model in mind, we can tell that's the whole point. We look at normative and abnormal at the same time. We see what differentiates the two. We see when things are normative, when they start to go awry. So to say that identity is still forming, sure, certainly there's a bunch of developmental models telling us different stages of identity development, but there's a very clear disruption in identity, even with teens who are still forming identity and consolidating their identity. When you work with these people clinically or when you have people in your life, there's a pretty clear qualitative difference between a normal, let's say 17-year-old, 16-year-old who identity is still forming, but relatively intact, like pretty coherent, versus someone who's really struggling with identity. So literally ask them, and this person might say, I don't know who I am. I feel empty all the time. And it might look different than depression. It's truly about no sense of self. So I would say these two things, these last two bullet points, we can really push back on using our developmental psychopathology framework because we are accounting for that. And that's what makes a PD diagnosis helpful if it warrants it. So in the last decade, and obviously longer, before 2013 really, research has shown that BPD is a valid and reliable diagnosis in adolescents. And so that really, just like any disorder, that points to early identification as being necessary and treatment as early as possible being necessary. So part of why people get so scared about BPD, whether it's a clinician or getting the diagnosis, is because of the stigma around it. And part of the stigma is because of the belief that it's hard to treat or because of all the associated risks or kind of some of the outcomes that you see. So you do see higher rates of hospitalization due to suicide attempts, suicidal ideation, and there tends to be comorbidity with a lot of other disorders. And so it can make it a really painful disorder. And so we see this population as being a little bit more high risk. And so that's why there's stigma. But if you see that there's all of this risk involved, then it's even more important to get people help as early as possible. Why would we wait till this person is 18 and presumably has already done many of these symptoms, perhaps has attempted, is self-harming, is doing really dangerous things? Why would we wait till after the fact if they probably have been doing it since adolescence? I'm not going to talk about this, but I think it's a really interesting podcast that Dr. Sharp, who I showed you earlier, gave on a podcast. So she talked about personality disorder, where the field is going, why there's stigma, why we can kind of debunk a lot of the myths. And so it's a really interesting podcast. I think it's like 30 minutes. So if you're interested, here's the link. So I want to show you a case vignette that comes from that Sharp and Fonagy. I'm pretty sure that's the article I signed you, and this gives you an example of a clear personality disorder in teen vignette. So I'm gonna like fly through this, so I'm gonna read it very fast, but this is straight from this article that they did a case vignette on. So Sarah is a 15-year-old adolescent who was admitted to an inpatient unit after she made a serious threat to kill herself. Sarah's parents got divorced when she was 4 years old, and she's been spending alternate weekends with her father. I think this is civil. Okay. On the day she was admitted to the hospital, Sarah's father brought her to the meeting point, a park, where he was going to drop off Sarah to be picked up by her mother. When he began to leave, Sarah clung to him and started to cry. Sarah has had a tendency in the past to engage in dramatic displays to stop her parents or good friends from leaving her. This time, Sarah told her father that living with her mother had become unbearable and that if he did not stay with her, she would kill herself. During the past 2 years, Sarah has often threatened to kill herself. Her father tried to calm her down, but she shouted that he was not hearing her, and she pulled up her skirt to reveal significant cuts and burns on her thighs. Her father was shocked. Since childhood, Sarah has always been highly emotional and reactive. Recently, her father had become concerned about Sarah's alcohol intake and the fact that she was caught shoplifting a few times, but her father had not been aware of any self-harm. Sarah disclosed that she had been cutting and burning herself for at least 2 years. By this time, Sarah was sobbing angrily and accusing her father of never being there for her and choosing a life with his new family instead of her. When her father tried to hold her to comfort her, she punched him in the face and started running away. When a car nearly ran her over, she collapsed, and her father was able to catch up with her to take her to the hospital. On admission, Sarah appeared completely calm and said she felt separated from her body, a feeling which she said she often has when she becomes stressed. She kept scratching herself. She did not want her mother to come to the hospital. So, this is pretty intense, right? Like, this is a teenager who clearly has a lot of turmoil going on. There's a lot to work with here. And so we can already, if you're familiar, if you've heard of the disorder, kind of already paints a picture for us that this does not feel, and I use feel like qualitatively, it doesn't feel like a run-of-the-mill depression case or anxiety. It feels like there's a lot more going on. There's a lot of interpersonal disturbance. We don't know much about identity here yet, but as far as the behaviors that are manifested, there's a lot of high risk behaviors that would make me concerned for her safety. And in fact, she's being hospitalized. So when we're just thinking about BPD because this is where we have the most research for adolescents. We need to meet at least 5 of these symptoms. So there's 9 total. Diagnosis would be warranted if the client meets 5 or more. And then, of course, some of the other qualifiers like no, not explained by something else, needs to be severely impairing, all that stuff still holds true. So, number 1, efforts to avoid abandonment, unstable, intense interpersonal relationships, identity disturbance, impulsivity in at least 2 areas that are potentially self-damaging, recurrent suicidal behavior. So this is not a suicide attempt. Let me see. Oh yeah, number 4. So don't count self-harm here, even though it might feel impulsive. Number 5 is where you'll account for that. So suicidal behavior, gestures, threats, or self-mutilating. So that's self-harm. Affective instability, so that's emotions going up and down. Chronic feelings of emptiness, inappropriate or intense anger or difficulty controlling anger, and then transient stress-related paranoid ideation or severe dissociative symptoms. So for this case, what do people, I don't know, you can put it in the chat or you can say out loud, what do you think, just hearing that vignette, are there any of these criteria that Sarah would meet?
The chronic feeling of like emptiness or 7 or 8, I think.
Yeah, I do think that I get that sense that that's what's underneath it. I don't know for sure if I might have forgotten already. Um, yeah, I think I'm getting that from this, but yeah, so that's one we might put a question mark from unless it's on here. This was a long vignette, but certainly like working with this person, I feel already that there's some emptiness, and that's maybe what's driving this whole dad versus mom feeling really left alone. The part where she accuses him of never being there for her and choosing a life with this new family. Yeah, that signals that there's some emptiness, perhaps. Good one. Other ideas that people think she could meet for?
Her efforts to avoid abandonment.
Yeah, that's a really important one, and I think probably we see this one come a little bit more clearly through than the emptiness. This efforts to like threatening to kill herself multiple times in this vignette. is an effort to not be left alone by dad. She doesn't want him to leave. So yeah, that's pretty intense, right? It's not, oh, I feel sad. It's I'm really dysregulated because I feel like you're leaving me. And this abandonment can be either true, like physically, like we're separating, or it can be imagined, like I feel like you're leaving me. And so I'm gonna do these things to really feel close to you. So yeah, that's a big one. So I see that one. Other ones? I'm gonna stop sharing for a sec to see if I'm missing anything in the chat. I think not, but we'll see. Avoids abandonment. Yeah, I'm glad I checked. Unstable relationships, impulsive. Yeah, exactly. So all of those things are exactly what I'm looking for as well. So I'm going to screen share again. So, oh shoot. Okay. Yeah, so we definitely see efforts to avoid abandonment. That's that running, like running in the streets, saying I'm going to hurt myself if you leave. This unstable, intense interpersonal relationships. You definitely get the sense that there's some instability and a lot of negative emotionality when it comes to relationship with dad versus mom. Identity disturbance. So at least in this vignette, we don't quite get that yet, but I bet you in the intake and since she's hospitalized, as we start to do treatment, it's probably going to be present, but not explicitly endorsed in the vignette. Impulsivity, for sure, someone mentioned that. So dad mentioned, yeah, I felt concerned about her drinking. And I think I can't remember what the other, maybe it was reckless driving, but we definitely see two areas of impulsivity. The recurrent suicidal behavior, definitely that's the self-harm. Affective instability due to market reactivity. So that's there was like a statement earlier that said she's always been like this. So that's kind of that like temperament and personality being very stable, that tendency towards affective lability. So, and it seems like she's gone up and down, up and down. The chronic feelings of emptiness. This one, yeah, I feel like it's probably there, but not explicitly endorsed. Inappropriate, intense anger. So, like, I feel the intensity in that vignette. And then this transient stress related paranoid ideation. So, that last sentence where it says, she looks really calm and her affect is flat, and she says she feels out of body. That's dissociation. So, yes, she's dissociating, and that becomes very common when people are very dysregulated inside. So, here we can see 1, 2, 3, 4, 5, 6, 7, nearly 7 out of the 9. And again, if we interviewed her a little further, we might see her endorse number 3 and number 7, but already she's above the threshold. So she definitely would earn a BPD diagnosis. So what makes that so interesting is that clearly this is someone who could use some help, right? We don't want her to hurt herself. We want to help really kind of dampen the emotion down. So just because she's 15 doesn't mean we should say, oh, well, we're going to skip this diagnosis. We're going to give her something else. It's something that we actually should consider and be really thoughtful about because it seems like she does need treatment. So keep that in your mind. That was like a pretty clear example of like, yeah, she meets criteria for all of it. It's pretty intense. And it landed her in hospitalization. So you do see higher rates of BPD or any personality disorder, more severe disorders in a clinical setting. Of course, that's why they've been referred for treatment or why they've been hospitalized. So the rates are artificially increased, but I mean, that tells you the level of severity that sometimes happens for them. Okay, so keep that in your mind, the BPD diagnosis for that person. We used a categorical disorder. We used BPD in section 2. Remember, there was 10 total disorders. We used one of them. So now I'm going to tell you about the alternative model of personality disorders, which is in section 3. So again, that's the emerging disorder section, or emerging models, emerging relevant clinical information, things like that. So the DSM-5 personality disorder work group is comprised of researchers, consultants, bunch of people with expertise in the area of personality disorder. And their work group they're the people that are charged with proposing any changes between DSM iterations. It's a very lengthy in-depth, like it's a monstrosity of a process. So to give you context, in 2007, so pre-DSM-5, so these were the people working on, oh, we really need to make changes from DSM-4 to DSM-5. So in 2007, the DSM-5 work group begins working on the changes that they're going to propose in DSM-5. Come DSM-5 being published in 2013, their proposed changes are not officially adopted, but they're included in the DSM, they're in section 3. Then 2022, so just a few years ago, we still have the DSM-5, but we have the TR. TR stands for text revisions. Anytime you see TR, there's like not really any major changes from the original, which is why if there were major changes, it would be DSM-6. So by the time DSM-5 TR comes out, it's still in the back. It's still in it's still in section 3. So I give you this slide just for context that this has been in the works literally since 2007, and we're at 2025 now. So literally over nearly 2 decades of work has really been put forth to try to show the clinicians and to show the APA workforce. And it's really American Psychiatric Association, which is psychiatrists as well as psychologists, that there is change that's warranted in the DSM-5. Ultimately, it's not really accepted into section 2. It's kept in section 3, which is helpful even then because people can turn towards it and look at, oh, there's another model here. I wonder what that is. So just know it's been in the works for many, many years. And this also another podcast by Thomas Whittaker. He's a trait-based person, which I'll explain what it is in a sec. But he talks a lot about what the hurdles were. So like why they even proposed, why it was never adopted into section 2. So it's an interesting podcast for timeline. So ultimately, DSM-5, section 3, so AMPD version, is now, it's kind of doing away with the categorical disorders. So the idea here is consistent with research, consistent with our knowledge of psychopathology, which we should think of along a continuum. It's dimensional. There are a lot of issues with the categorical disorders, and that's true for all the disorders. We talked about comorbidity, heterogeneity. Why is it that you can have 2 people with the same diagnosis of major depressive disorder, but they look really different? Why is it that this person, so that's heterogeneity within a particular disorder. There's also homogeneity with other disorders. So like why do I have MDD and GAD, and like there's a lot of overlap between the different disorders. So that's also what's accounting for high comorbidity. Think of that, remember that, but especially in the personality disorder section, when we look at the 10 disorders, there's a significant amount of overlap. So a lot. Like if you're diagnosed with BPD, it's very likely that you have a histrionic diagnosis as well. If you have OCPD, maybe you have schizoid as well. Like there's a lot of overlap to the extent that it feels it's concerning and confusing. Like why then do we have so many disorders, these 10 different distinct disorders, when they're really not all that distinct? So the DSM-5 work group, what they had been proposing was this AMPD. And the idea initially was to just do away with the categorical system and make it dimensional. So rather than saying you have XYZ disorder, you have BPD, narcissistic, blah, blah, blah. Instead, we'll talk about a generic personality disorder where we think of personality functioning along a continuum, just from normative to maladaptive. So that already makes it dimensional, and it actually puts it back to like a less stigmatizing framework because everyone lies on this personality functioning scale. And we really think of it as personality pathology that fluctuates up and down. And when you lie on the severe end, more often than not, that's where you really fall into this personality disorder territory. And rather than saying, okay, you need to meet 5 out of 9 to get BPD, you need to get 5 out of 9 to get narcissistic, we think of it as 2 things that need to be true. We're going to look at your level of personality functioning, and we're also going to look at your traits. So personality functioning, criterion A is the level of personality functioning, and it's really assessing any disturbance in your self-functioning and your interpersonal functioning. So we think of that as like the core of personality pathology. It's kind of the why. It's like the primary dysfunction or disturbance that's driving the behaviors. So if we think back to Sarah in the vignette, there's clearly some self and interpersonal functioning disturbance, like that feeling of abandonment, having such anger towards mom and dad, feeling of parent, step family taking over dad from her life, signals some sort of interpersonal functioning disturbance. Now, I'm not saying that's not valid. She probably feels really sad and angry, but that extent of emotion signals that there's that interpersonal functioning section of the domain is really high on the severity end. If we were to ask her about, like, do you feel empty? Like, do you know who you are? Most people can give you some sort of, depending on age you're in, um, pretty consistent adjectives or ways of describing themselves. When you're in college, a lot of times part of your identity is I'm a college student, but you're able to talk about, um, I'm a person with strong values. I am someone who cares about other people. I'm diligent. I like soccer. You're able to describe yourself in that way. That capacity obviously grows and grows and grows as you get older. So that level of detail you're probably not going to get from a 13-year-old, but there's still some sort of coherence there, like that ability to form identity. That's a developmental task that everyone goes through. With personality disorder, you see that a lot of times there's some sort of interference in the self domain. So we do interviews in my lab where it's a diagnostic interview using the AMPD. And one of the questions is, tell me what kind of person you are. Tell me about your self-esteem. I'm obviously cutting it down, but you'll get answers like, I have no sense. Like I feel chronic emptiness. I remember doing an interview and someone said, if my life, like how I feel, like if you were to ask me who I am, I would just tell you, like, this is what someone else has said about me, but I have no like attachment to that. It feels like, God, they used a really interesting analogy. Oh, it felt like waiting at the bus stop, and each time like a new group of people get on the bus, like I'm just left outside, like I'm still outside. I have no sense of what it's like to be with others. I can't really drive the boat for myself. It was really interesting and really sad, but I think people underestimate that this self interpersonal functioning domain like really drives personality disorder. So if you're going to use this AMPD model, we're going to assess what's that level of impairment. So the higher levels of personality functioning would be more maladaptive impairment in self and interpersonal functioning. So that's kind of like one camp of the workforce. So they propose this, and they believe that this really explains, this is the why of personality pathology. This is why we have personality disorder. Criterion B, so that's the next criterion level, is now we need to see pathological personality traits. This is really mapping on to the 5-factor model. So that was normative personality traits when we thought about OCEAN acronym. So there's been research, and again, also factor analysis, a lot of quant methods, so statistical methods for deriving these 5 pathological traits. But in theory, they kind of map onto those big 5. And the idea here is that there's going to be some sort of constellation of these traits, high negative affectivity or low, high or low detachment, and so on. And that's really, going to drive what you do. So in my lab, we think of it as criterion A is the why, like why do we have personality pathology? What's underneath it all? Criterion B, the traits, is kind of the flavor, like what you do, why it feels like. So if I see high levels of antagonism, that makes me think a little bit more about narcissism. Like there's high levels of antagonism, but at the core of personality disorder, we're going to see some of the self and interpersonal functioning. So the traits are also very important, and they really complement criterion A. Ultimately, if you were to use this formulation, in the DSM work group, they originally said, like, criterion A, people said this is what should be proposed, like do away with all the categories. This is really all you need. Criterion B, people said, no, it's really all the traits that explains everything. It doesn't really matter what criterion A is. The traits are mapping onto temperament. It explains the flavor or like the constellation of flavors of why you see certain behaviors. Just do traits. And then you had other group of psychiatrists and other people who said, what do you mean AMPD? What is that? Like, that makes no sense. Let's just keep the categories. Everyone understands it. Let's stick with it, which is not necessarily in line with the research So you have different camps. No wonder by the time they proposed it to the work group or the APA workforce, it wasn't cohesive enough. It felt, not really sure what we were going to do, because what they proposed was this thing on the right, which is a way of appeasing everybody. So they said, okay, step one, you're going to assess criterion A. Step two, you're going to assess criterion B. And then to appease the categorical people, you can still give a specifier of borderline or whatever the category is. And then you're going to signify like how much severity there is in terms of criterion A and criterion B. So it kind of felt like a hodgepodge, which is why it really got moved to section 3. But the idea of keeping this specific personality disorder specifier was really just to appease people who wanted to keep the disorder, the categories, and in terms of like practicality, because it's probably going to be really hard for clinicians out there to adopt this framework so quickly. So there was good reason, but ultimately that's why I wasn't accepted into section 2 of the DSM, just because it was too piecemeal at that time. So since 2013, now onwards, they have worked tirelessly just to show evidence of all the different like reliability, validity measures properties we need to be looking at. So there's a lot more now evidence on how to use the AMPD, how to really integrate criterion A and criterion B. Yeah, so this slide here is basically explaining what this image is on the right. So criterion A, I just want to show you, I talked about self and interpersonal functioning. We can break that down further into identity and self-direction, empathy and intimacy. So it's really, think of it as difficulty managing the self in the context of others. My lab and my advisor in particular is a huge criterion A person. And what makes us so, like, I guess, powerful to use in a clinical sense is if we just describe personality pathology as, on most days, more often than not, we really, on that scale, that function, so 0 to 4 down here, 4 being the most pathological. Really, it's just a disorder of managing the self in the context of others. We get a little bit confused, we struggle, our emotions get high, whatever the case may be. So really, we just need to work on self-functioning in the context of others. That language makes it a lot more digestible. And if we think of depression as just a disorder of mood, which people don't really blink or think twice about. If we talk about, I'm trying to think of another, substance use as just a disorder of using substance, we can make personality also something that's easily digested. It's really just a disorder of managing yourself in the context of others. That really destigmatizes it, and actually it's a good treatment target to help you make yourself like a coherent person, plus how you interact with others. I'm just going to show you an extra slide. I'm not going to cover that. We kind of talked about the traits already. So in theory, they map on to the big 5. Here's just definitions of what the different traits are. Just to clarify with this top images though. So these 1, 2, 3, 4, 5 are the trait domains. So those are the things that map onto the big 5. But within each domain, there are facets. And that's what the, 25 plus qualifiers are. So if you like kind of mix and match them, that's really what drives the actual behavior we see, let's say, in BPD. So with BPD, we can see where criterion A is. It's really having a hard time making sense of the self, especially with other people. And then in terms of the actual behavior of reckless spending, threat to hurt yourself, like, dissociating, you can see that it pulls from each one of those domains. That's what we mean by flavor. It really explains why there's a constellation of traits here. So I already kind of touched on this, but there's a red text box here just to show you that qualifier there is really what kind of, I think, like dinged the work group when they proposed this to APA, because why would you propose a dimensional model but then retain some of the qualifiers? So there was, again, good reason to do that. But just, be aware that it did try to retain the disorders just to be helpful in terms of the transition and to appease categorical people. And just a note that, so DSM is our Diagnostic Statistical Manual of Mental Health Disorders. The ICD, the International Classification Disorder System, is a worldwide, more global classification system. If you are familiar with like insurance reimbursement, if you go to therapy, anything like that, they charge the ICD code. So this is what like insurance companies use to reimburse services. And so that's really important because already the ICD-11 has already adopted basically that AMPD with a few tweaks. But I think that just goes to show that like this is where the field has been heading and in fact has already been adopted in the ICD. So food for thought. It's not something that's like, whoa, we've never considered this. Like no one's going to use this. It has been adopted by the ICD. I'm going to skip this. I want you to read this though, but there are a lot of strengths of the AMPD. I think for us, remember we're talking about child psychology, the AMPD really maps on well to developmental psychopathology. It helps us explain why we can talk about personality disorder in youth, because if we think of that normative up and down this scale, we're able to pull from different frameworks and say this is still abnormal given the child's developmental age. This is straight from that paper too, like literally plugging in a BPD diagnosis with an example developmental psychopathology framework. So how do we integrate all those risk factors? And it's also consistent, sorry, with biopsychosocial theory, which is used in DBT, which I have like a few minutes, so I want to hit that before we end. I'm putting the medication slide before intervention because I think it's really important. So medication. There's no FDA approved med for personality disorders specifically. So it's not like depression, we use SSRIs. There's not a specific medication for BPD or any personality for that matter. Instead, when you see people prescribed medications, it's really to ameliorate or reduce the comorbid symptoms. So things like depression, or if there's like that extreme lability, you might see an antipsychotic being described, or sorry, antipsychotic being prescribed. It's to help with those comorbid symptoms. It's not actually treating the core personality pathology. So keep that in mind. It's not that you never see people. In fact, you often see people with medication, with BPD or any personality disorder. Just know it's not treating the core personality. I'm going to skip this because I think that Kennedy and Tess will do a good job, but this slide is really just doing a head-to-head comparison. Like on the left is the BPD diagnostic criteria. On the right is how we would reconceptualize in terms of AMPD criteria. In terms of research, just know that in proposing this AMPD, criterion A, criterion B, BPD is like one of the closest, like easiest transitions. So there's a lot of research showing that AMPD sufficiently covers everything in section 2, all the BPD diagnostic criteria. This is just another case vignette, but here's how we would conceptualize it. So if we read a vignette, we'd be asking ourselves about criterion A, self and other. So we're going to be asking ourselves, does this person have a clear sense of self? What about their self-esteem? Can they maintain who they are in the context of others? For traits, we're also just going to ask, like, do we see any like temperamental traits that happen from childhood onward? What are some of the behaviors? We also might give a screener, which tells us like the constellation of traits. And then ultimately, if we're going to convey a PD diagnosis, when it comes to the alternative model, rather than saying this person has BPD, remember it's dimensional, we're doing away with the categories, we would say this person meets criteria for personality disorder. And here's some things that we want to explain to you. Like we would give psychoed about destigmatizing. We talk about how there's advancements in the field, how we really just think of it as we lie high on this continuum and we really just want to get you a little bit more towards the middle with treatment. We talk about parenting. So parents are very, very integral for helping scaffold the child's personality functioning. So we include the parents in it. And most importantly, we say that's a very treatable disorder. People get really, really scared when they see this diagnosis of personality disorder and they think my child's going to hurt themselves and kill themselves or whatever, won't be alive much longer. So you really try to instill feelings of hope that it is treatable, especially with early diagnosis. Okay, so remember we have medication prescribed for a lot of the co-occurring symptoms, not really treating the core personality. When we think of what the evidence-based treatments are for personality disorder, there's 4 different types I want you to keep in mind. I'm highlighting the 2 in yellow that I want you to know the most about. So DBT, dialectical behavior therapy, is one of the frontline treatments. It's a skills-based approach. So it integrates CBT, acceptance and commitment therapy, mindfulness-based therapy, and the goal is really to have a life worth living. So in DBT, I'm currently doing my practicum at the DBT Center of Houston. We think of acceptance and change. So we have to have acceptance in order to change. So we teach skills so that each skill falls within one side of the dialectic. And we talk a lot about dialectics. So finding some sort of synthesis when 2 things feel seemingly opposite of one another. So we can be in pain and we can work towards change. We can want to hurt ourselves and need to use skills to try to ensure that we have a life worth living. So there's a lot of nitty-gritty things we do in DBT, and these are just extra videos if you want to see it. I show you this because I think these are like very hallmark important things to know about DBT. We use a diary card, so it's behavioral in the sense that we're tracking behaviors. So if you're self-harming, I have a client who self-harms, throws up, skip school. So all of those behaviors I target in the diary card. And then there's a very specific way of addressing these behaviors in DBT. One of them being a chain analysis to look at what are the links between your emotions, thoughts, and ultimately the target behavior we're working on. So let's say self-harm. And then we kind of plug in like what are skills that we can use. And we're like facilitating like conversation about dialectics to try to get some sort of insight. Okay, the other one is MBT, mentalization-based treatment, and this is really one of the best ones for mapping onto self and other. So the DBT is a lot of like skills-based work, and it really addresses the behavior. MBT is more from the criterion A perspective of self and other. So MBT is really about scaffolding your sense of self, helping you kind of like slow down, be able to make sense of your own thoughts, not get caught up, and use the therapist relationship as a sort of a model for we call it mentalizing. Okay, and then that's just the last picture I wanted to show you. Again, in therapy, this is how we use MBT and how this relates to self and other functioning. And then again, extra videos for you guys if you want to see. These are old, but it's a role play with MBT versus DBT. And that's basically all I wanted to cover for today. So I flew through a lot of these things. So on Friday, please just go back if you can. That way you can kind of go and watch the videos. You can slow down around some of the AMPD slides that I skipped. But I really just wanted to hit the entire PowerPoint before we see each other on Wednesday. So Wednesday, 2 days, we're going to have 2 guest lectures. And then Friday, we will not meet. So use that time Friday to read the rest of this. I know we're exactly at 10. Any questions about what we just talked about? No. Okay. If anyone, correct, 2 guest lectures on Wednesday. Yeah, so you'll need to attend. There's nothing you have to do other than come to class. There's 2 people that are going to be speaking that day. So come on Wednesday, and you have any questions? I have office hours right now, so I'm going to switch to the other link, but otherwise I'll see you all Wednesday. Okay. Thank you, you too.